But tonight we're going to present to you the Renal Education Forum, and we're going to begin with Dr. Beaulieu. Dr. Beaulieu is trained in the clinical nephrology and has a master's in health administration from UBC. In addition to the general nephrology, she has special interest in chronic disease management, implementation of systematic care systems, and system redesign, as well as pharmacological optimization in CKD patients. Did I say that all right? Sure. Okay. She is the director of the Integrated Care Clinics and co-director of KSC and medical lead for PHC nephrology, as in quality and safety. She has recently started an innovative obstetrics and gynecological nephrology clinic, as well as an integrated care focus. Her research focus is in CKD and continuous quality improvement. She has a provincial role in the BC Renal Agency and has been on staff at UBC since 2008. Please welcome Dr. Beaulieu.
Basically, I'm Monica. I'm a kidney doctor, and I really love what I do. Thank you all for coming today. We're going to play it a bit by ear and make this a bit interactive, but what we want to do today is really threefold. We want to talk a little bit about the hope with respect to patients living with kidney disease. We're going to talk a bit about the best ways to provide dialysis and a lot of time on the best ways to provide renal transplantation. We're going to talk a little bit about some research initiatives that are coming down that are quite exciting and never really have been seen before. And we're going to talk a little bit about, I know many of you either have or know someone with kidney disease, but a little bit about kidney disease in general, because as you know, it's not really one of those things where you go and talk to people that they, heart disease comes up, other things, but kidney disease isn't usually front of mind when people say, what do you do? And you tell them you're a kidney doctor. They go, oh, why did you do that? So we're going to talk a little bit about that. And this is really presented on behalf of our whole kidney program. We have hundreds and hundreds, as you know, of doctors and nurses and dietitians and social workers and nurse practitioners that care for all of you and your family. And this is just a snippet of what we do, and hopefully teach a little bit and be able to answer any questions that you have. And so I don't know if it's surprising to you, but the stats are that an estimated 1 in 10 British Columbians actually have kidney disease, and most people don't know that they have it. I'm sure any of you that have experienced kidney disease, most people come to us and say, but I feel fine, but I don't have anything. It's one of these silent conditions until things get quite late sometimes. And that's why it's a bit of our passion to figure out who is at risk and to diagnose them early. And some of the work that Dr. Levin's going to show you in terms of trying to prevent worsening once we identify those patients at risk. It's exciting to know that if we do diagnose it early, then progression can be slowed and can sometimes be stopped completely. And so I'm just going to probably do something I shouldn't and walk you through a website using technology that talks a bit about a kidney disease self-assessment that you can use for your friends and family and maybe yourself. So you don't have to read through it all, but it is on the BC Renal Agency website. And it basically tells people that you can be at risk of kidney disease without even knowing it. And I'll talk a little bit about the common questions that we ask. I don't know if you guys know, but when you go to your family doctor, screening for chronic kidney disease isn't something people do routinely. You have to ask for it. Other things we universally screen for, but kidney disease right now isn't one of them. So often when those risk factors are triggered, then of course the doctor will screen for it. But if it's a son or a daughter of yours and you don't bring up that mom or dad has kidney disease, then that might not trigger screening. So we want to empower all of you and your circle to make sure that you know what those risk factors are, so people can go and say, actually, I do have a risk, I want to get screened. And so we'll see if this actually works, and I'll walk you through it. So anyone, say you do have diabetes, say you have high blood pressure, but you're absolutely treated, you have no problem. Have you ever had circulation problems, angina, heart attack, stroke, or mini strokes? Let's say you're fortunate enough not to have any of those. If you've had kidney stones in the past, if you've had urine infections in the past, often questions that people might not even bring up. Let's say you had kidney stones. If you have certain diseases that put you at risk, usually you'd know about these cancers or autoimmune conditions. Those all put you at risk, but sometimes it's not the first thing people think, oh, you have HIV disease, I better check your kidneys, but it puts you at risk. If you have a parent or a child that has kidney disease, even if it's not an inherited condition, so by virtue of having someone in your immediate family with kidney disease, you are at risk. And if you ever had a urine test, often we don't do urine tests. People will do blood tests but not do the urine test. So when you go in to have your kidneys checked, a urine test, did they do a urine test? That it should always come with the blood test and say you did not have any problems in your urine. Another big one is medications. Some people have to be on medications for psychiatric conditions and others that actually put their kidneys at risk. Sometimes it's as common as going to the pharmacy and getting some Advil or Motrin or ibuprofen, where we all do it and think it's okay. That puts you at risk if you have to use it. And so it'll come up with a kind of a snapshot for whoever takes it and says, based on your responses, talk to your GP about having a kidney test done. And then we do have very simple online apps for the family doctor to say exactly what they're supposed to do with the results that you have. So I encourage you to talk to friends, talk to family, say, have you done your kidney risk assessment? So, I'll try to be good. So just to let you know who we are, we're only 12 doctors, nephrologists here at Providence, and about 22 in our health authority, which when you see the numbers, we think, oh, no wonder we feel so busy. But we care for at least 3,500 patients with CKD that aren't on dialysis. We care for about 600 hemodialysis patients, either in a hospital or a community. We care for 62 patients on home hemodialysis, so doing their therapies at home. 227 patients on peritoneal dialysis, and Dr. Landsberg can probably tell me it's probably even way more than this, but well over 1,000 patients who have had a kidney transplant. So a lot of patients that we care for in our health authority with kidney disease. And I just wanted to, it's not to read the slide, but I just wanted to talk about the first, when we thought about what we needed, what we could do better. We actually have one of the highest rates of independent dialysis. I say in Canada, but anywhere. So independent dialysis is patients doing their peritoneal dialysis at home or home hemodialysis or in a center but without a lot of nursing support. And really for so many reasons, for the patients, quality of life, quantity of life, flexibility, diet. It's the best treatment. It's cheaper. It's lots cheaper, and people do better. So it's kind of a no-brainer. But when we thought, what's the challenge of getting more and more patients on independent dialysis? For any of you that have gone through the training and others, it's a slog, right? Dialysis is free in our healthcare system, but we have so many patients that have to relocate, they have to go to the Sandman Inn, they have to have their training, they have to take up time off work. And so we really are working on innovative ways outside of the normal payment of the dialysis to try to say, how can we support people so they choose this therapy that's obviously better for them? So why would it be a deterrent to do something that's the right choice because of financial or other concerns, constraints, or putting them at a disadvantage? So we don't know the answers yet of how to make that easier, but I think we have to, because I think a lot of people are choosing facility-based dialysis just because it's really hard to relocate, take a lot of time off work, get training. They might as well just, go in and get things started. So it's something that we are working on, and there's some time at the end, we'd love to take any suggestions. I'm going to move a little bit towards transplant. I won't say much at all, just Dr. Landsberg is going to talk about most of it, but I don't know if you guys know that we're kind of at a really, really exciting point in kidney transplantation. So, we have an amazing program at Providence. It's looked on Canadian-wide, but our numbers, we're doing more and more and more, and we don't know where it's going to go up. So these are organ donors from deceased donors, so people that have graciously donated after death, and see that number going up at the end. It's actually going up, and I don't know what the number is for 2016 and 17, but it's definitely not plateauing, it's going up. And the exciting part, and what we're trying to stimulate a lot of interest as well, is this is living donors. So sometimes people will say, well, I'll be a living donor just because there's no way my family or loved one's going to get a deceased donor because that wait list is so long. And sometimes when we reduce that wait list, then we think, oh no, the living donors are going to not be there as much, and they're actually not. And that number as well is going up. And we're going to talk to you a bit about why that is so important. So I'm going to leave you with just a couple 1-minute videos, and I thank the Kidney Foundation who helped put these together. These are from patients. They're only a minute and 10 seconds each, and it really makes us, every time you see it, show how important donation is. So if I can get them to work, we will do a couple videos, and then I'll take any questions and introduce Dr. Landsberg. Let's see what we can do.
My name is Mimi Luke, and I'm a life coach, I'm a writer, and I'm also a public speaker. My health is great. I had a transplant in December 2012. My friend donated his kidney to me, so ever grateful for that. So it's been a good recovery, and I'm feeling great these days. If you're even considering being an organ donor, I will say do it without any hesitation. You can't imagine what a gift that is you're giving to the other person. I mean, you are saving that person's life. And not only are you saving his life, but think of all his or her family and friends. I mean, just the ripple effect that you will have by your gift of kindness. I would say do it. I mean, think about it. If you or your brother or your sister or your husband or your wife or your child needed a kidney, just really put yourself in that position and just think about how grateful you would be if someone stepped up and said, I'm going to donate my kidney to you.
So I'm going to show one more, and then we actually have the good fortune of having real patients to talk to us today. This is Teresa.
My name is Teresa Atkinson, and I've lived with kidney disease for the past 30 years. I am a housewife, and I have 4 grandchildren, and I love playing with them. Having had 2 transplants, one that didn't take and one that was my sister's, a living donation, now I have very high antibodies, so it's going to take a very special person to match me. A transplant is my only real option to stay alive. I've had so many accesses over the past 30 years that I have very little veins left, and I'm probably on my last neckline. Not probably, I am on my last neckline, I know that. And if I don't get a transplant, I will simply die because I don't have access to clean my blood. To me, it's going to be life and freedom and time to spend with family and loved ones.
So some of the challenges that Teresa mentioned, whereas they were challenges before, they still are, but there are programs, there are initiatives, there are stretching the boundaries and thinking outside the box. And so we're really trying to open up what is possible for kidney transplantation. And so without saying much more about it, I'd like to ask Dr. Landsberg to speak. I won't formally go through his bio, but when I saw the warm greetings when people walked in the room, many of you know Dr. Landsberg. He was our division head here for many years, is the head of transplant here, and now has taken over actually as the medical lead for transplant for all of British Columbia, and involved with many national organizations. So I'd like to welcome David today to talk to us.
Good evening, everyone. Hi. So I know a number of you in the room, and I'm anxious to get to know other people if they have questions, of me. I think my major goal tonight is to be able to provide information and to give you a sense of where transplantation is. I'm going to focus on St. Paul's Hospital, but we have a provincial transplant program based at Vancouver General Hospital and St. Paul's Hospital, and we work very much as a one program at 2 sites. That being said, at St. Paul's, we feel pretty strongly that one of our real strengths at St. Paul's is our renal program, and we're very proud of our renal program. And transplantation is a very big part of that. Just a little bit of history. St. Paul's was the last program to be developed in Canada. Transplantation really got started in the late 60s. Before that, there wasn't any anti-rejection medication, so people couldn't get transplants unless they had identical twins because the body's immune system would just go ahead and reject it. When people discovered anti-rejection medication, transplant programs got started, and there were transplant programs developed pretty much across the country. Strangely, in Vancouver, there was a transplant program in Vancouver General, which I think, even in retrospect, I think the people who were the founders of that program, who led that program, are now mostly deceased. So I won't get back to them, but I think general consensus was they weren't really up to date. And St. Paul's has always been very, very patient focused. And I think all of us here owe a great debt of gratitude to Angus Ray, who is the founder of the renal unit and the renal program. And he was really struck by the fact that patients in BC were not getting transplanted at the rate that patients in other programs were. And so Angus is a man of action, and Angus decided to do something about it. And he lobbied very hard for there to be a transplant program at St. Paul's Hospital. And I'm incredibly blessed that that program was established, and I'm incredibly fortunate that as a very young nephrologist whose passion was transplant, I had the opportunity to come to Vancouver and to start that program. And that was in 1986. So we've done transplants now at St. Paul's Hospital for 30 years, and in those 30 years, we've done about 2,500 transplants. Now, some of those are people that have had repeat transplants, and not everyone is still with us. But so we're following a large number of people. And one of the things that also was happening in Vancouver is that there wasn't any commitment, and there was actually a feeling that living donation was not the right thing to do. And I came with an attitude that living donation was very much the right thing to do, and we were able to then establish a living donor program here, and our living donor program has grown, and we are definitely the leaders in Canada in terms of the access, I think, that we give people for living donation. We're the leaders in Canada in terms of just the pure numbers of living donor transplants that we do here, and our commitment to it. And I'm very proud of the fact that we also pioneered the non-directed anonymous donor. These are individuals who are willing to donate a kidney to anyone. And before we sort of took up that charge, people in the rest of the country said, well, we don't think that's not really ethical. We shouldn't be doing that. And the value of that is tremendous. I'm sorry I don't have a slide, but the non-directed donor has so much ability to help a large number of people because of the fact that we now have the kidney paired exchange program. So if someone is incompatible with, there's somebody who wants to donate a kidney to you, but they can't because they're not compatible, these pairs can enter into a registry, and then with the registry we can find matches and exchanges, and we can actually do a domino where this person donates to this person, then this person donates to this person, then this person donates to this person. But it's very challenging if at the end of that long chain, the last person in the chain has to come back and be able to donate to the first recipient, because that's just hard to match. But if you have a non-directed anonymous donor, then they can start off the chain, and they are not tied to somebody who needs to get a transplant in return. So one donation can lead to 6 or 7 transplants, and at the end of that chain, then there's a donor who can then donate to the wait list. So this non-directed donor can help 7 or 8 9 people. The biggest chain we've done so far is 6, but we potentially we could do more, and still somebody on the wait list got a transplant. So we're very, very enthusiastic about that. So, for people with kidney disease, and I want to be careful with people, with the audience, because unfortunately, transplant is not necessarily the best treatment for everyone. And there may be some in the audience, and certainly there are many patients in whom transplant really isn't a realistic option. And the reason it isn't a realistic option is because the outcomes won't be good enough. And the outcomes for the transplant would be worse than the outcomes on dialysis. When the outcomes with transplant are better than dialysis, that's when we strongly recommend transplant. And fortunately for many, many people who are looking at kidney failure, transplant is the best option. We are able to offer living donation and the waiting list, and those really are not in conflict. I mean, there are enough people who are on the wait list that living donation will never, I think, push out the wait list. But if somebody is fortunate to be able to get a living donor transplant, then that's the best treatment. It's the best treatment because it allows you to get a transplant earlier. And the best case scenario is to be able to get what we call a preemptive living donor transplant. So that's a transplant before you have to start dialysis. So it makes so much sense. Why go on to dialysis, have the creation of a fistula or a PD tube, go through the training, the trauma of starting dialysis, when if at the right time, you could just go right to transplant. Because there are so many people on the wait list, we need to transplant people who are on dialysis rather than people who are nearing dialysis, because we just have such a large number of people on dialysis. So the only way you can do that is with a living donor. So our success rate in getting people preemptive living donor transplants has been good, and we lead the country in that by quite a large margin, but I really believe that we can do better. So we have an initiative where we're partnering with BC Transplant is partnering with BC Renal Agency and the kidney care clinics across the province, where the idea is living donor first, transplant first. We talk to people about home modalities first, peritoneal dialysis first, starting dialysis with a fistula, but the best thing would be transplant first. And that's where we would like to go with transplants, so that we can offer more and more living donor transplants for people before they need to start dialysis. And that's really where our program is in large part going. We need to do a better job for our living donors. When we talk to living donors, they say to us, it was 90% will say it was one of the best things that I've done in my life. However, you guys really made it tough for me. Really, it wasn't that easy to be a living donor. And I really want to make that, I really want to change that. For the people who want to do it, we don't want to in any way rush people who aren't ready. But on the other hand, for people who are ready, we need to shorten those times. And so a major initiative, and hopefully with some outside help, because we are limited by the resources that we get from BC Transplant and Provincial Renal Agency and ultimately the Ministry of Health. If we can invest some dollars into that, I think we can create a program where we can serve our donor population in a much better way. And we also, I think, owe it to the donors to follow them in the long term. And again, we haven't really had the resources to provide the type of donor follow-up, which I really think is key. So these are some of the areas we're looking at. But for those of you who need a transplant but don't have a living donor, we're doing much better with our deceased donors as well. So Monica showed you the graph. We were the worst in the country. So BC was not doing a good job with deceased donation. With changes at BC Transplant and a commitment that transplantation, offering donation to families of individuals who were in a position where they could be donors, was routine part of end-of-life care. This wasn't something extraordinary. This wasn't something that you were imposing on people. You were upsetting them. In fact, families welcomed that. And so when BC Transplant embraced the intensive care units and actually developed champions in intensive care units, intensive care doctors who believed that transplantation, organ donation was part of end-of-life care, things turned around. And so you can see we've gone to the worst, from the worst in the country to the best in the country, also with the best living donor rates. So I'm pleased to tell you that the gap, the gap between us and the second best is sizable. However, again, I think, we can do better. So I'm incredibly passionate about transplantation. I'd be more than willing to answer questions about, the nuances of transplant. But the bottom line is that it is a good treatment. But the body's immune system is smart. The body's immune system is very well developed, and left to its own devices, there's going to be rejection. So our challenge with transplantation is our anti-rejection drugs, preventing rejection, but minimizing the side effects of drugs and monitoring patients for transplantation, for rejection, getting the right amount, not too much, not too little. Just right. Just right is a bit of an art, but we'd like to make it more of a science. And again, a lot of our research enthusiasm is around developing protocols that will be just right. And another thing that I'm very proud of is, in terms of just right, is that we are able to offer for 60% of our patients a transplant where they don't need to get long-term prednisone. Prednisone is a nasty drug. Prednisone, on the other hand, is a life-saving drug. So I don't want to tell people that it's a failure if you need prednisone. But we're the only program in Canada who does this, who doesn't use prednisone routinely in patients who we think can get away with it, and our results are good. So just to give you a flavor of what transplant's about, we do have both a previous living donor and a transplant recipient who have been graciously joined us and are more than willing to say a few words. And I guess the most interesting twist is that Kerry, who's the recipient, this recipient that this transplant that she received is her second transplant. And she was able to get it preemptively before she needed to start dialysis. And it was Lauren, her partner, who wanted very much to help her. They weren't compatible. So they were able to use the paired exchange program for Lauren to make a donation, give an individual who needed a transplant that success and that option, and Kerry got a transplant. And so everybody won, and they're here to share with us. I'm not sure who's going to go first, Lauren or... They'll both come up. So Kerry and Lauren are donor and recipient pair. Not they're together, but not directly. But Lauren's kidney is not in Kerry. Although I think we always, when this happens, we sort of think of it as that, and they're going to share a little bit of their story.
Good evening, everyone. I've been a patient of St. Paul's for 22 years out of their 36 years of their program. And I have had excellent care for those years. The pictures that you see here, this is a before and after photo. My first donor, the legendary Bob Barker, but for him, that's really his name, but he's my hero. I have polycystic kidney disease, and I learned that I had that when I was 16 years old, and it did show up as a result of, it just really felt like a searing, burning pain. And so then, therefore, it was discovered that my father had it, and my grandmother was already on dialysis. So Bob was one of my father's best buddies, and he came to our family and said, you know, if Kerry does need a kidney, I will donate. And he did. He was 54 at the time, and I was on dialysis just for 3 months. And then I had my first transplant. And that was back in 1995. I was 30 years old. And then I've had a second transplant, but the first transplant was very different from the second transplant. And it just showed me how far technology had come, how far the doctors at St. Paul's had come. So they were very, very different. With dialysis, that's when I met Dr. Adira Levin, and the care was they just made it very. I was not afraid, and I took to it quite well, and we got through it. Bob Barker is St. Paul's first donor of a living, unrelated kidney. So I'm the first recipient of an unrelated transplanted kidney. And that kidney lasted for 18 and a half years. He was 54 at the time. And those were great, healthy, wonderful years. And then as I went, I met Lauren in 2005. And we've been together for 10 and a half years. And 5 years into our relationship, my original kidney, it started to fail. And she didn't hesitate. And when we were faced with that, again, St. Paul's Renal Transplant Program stepped up to the plate immediately for us. It happened very quickly. Within 3 months, it was determined right away that Lauren was not compatible with me, but through the paired exchange program, it really went very, very well. That's really my story. But it's a very humbling experience when you have a disease or a health problem. But it's also been humbling for me to have such generosity in my life, and to have such great care. Every month I go for blood, and I only have to go to kidney clinic twice a year. So that's, and I'm a proponent as well as having the least amount of anti-rejection drugs possible. I continue to ask if we can lower things. I take about 5 milligrams of prednisone every other day, and I have continued to do that for many, many, many years. The adjustment to those drugs was severe, I would say, in the beginning in 1995. I think I was on higher doses of things like cyclosporin. But even the second transplant seemed to be the drug adjustment then. Of course, I'd been on anti-rejection drugs for so long, it didn't really affect me. But I know that this new regime of drugs is better for me and is as low as possible. My life seems maybe 1 or 2% different because I'm a transplant recipient. It's because I have to remember to take my drugs, and I have to go, to do my blood. It's the least that I could do for all the generosity from the people in my life that love me so much, and the care that I get. from the Renal Program. They are world class. I cannot say enough about the team. I know a lot of people there, 22 years of relationship. Any support that anyone can give them is paramount. And for the advances that they've made and the care that they give to me and all the fellow patients, it is profound what they do this is a snippet, a little story of one little person's life, but it is truly humbling. So for the donor side, Lauren.
My mom had a kidney removed many years ago because of cancer. Well, I'll get to the bottom picture in a minute, but the top picture was the morning, probably at 5:30 in the morning, getting ready for our surgery. That was June 20th, 2012, and I went in the morning and Kerry went in the afternoon. But I was saying, my mom had a kidney removed many years ago because of cancer, and I always said in the back of my mind, I said, okay, Lauren, keep healthy, because if she ever needs a kidney, I would want to be able to donate one. And lo and behold, many years later, my partner would need one. And Natalina, you had asked me, what was the decision to become a donor like? And there wasn't a decision. It was just a given that I wanted to get tested and see if I could be a donor. And it is for selfish reasons, really. I just wanted my partner healthy. And I wanted to try and help to get her transplanted as soon as possible so that she wouldn't get really sick and that we could preempt her going on dialysis. And so I must have been the 10%, David, because I had an amazing experience. My testing happened probably from November to January, and found out at that time, at the end of January 2012, I remember that I was approved to be a donor, which was great news, but found out I wasn't a match for Kerry, which was, in the moment, really devastating news. And it wasn't because I needed to be the donor. I just wanted somehow for her to get a kidney, and I knew that this would be the fastest way. But that quickly melted away because we knew we had a really viable choice, second option, and our plan B of the Living Kidney Donor Paired Exchange Program, which we had been learning about. And so as the tears dried up and suddenly it was, okay, what can we do? And he really reassured us that we could get into the registry. And as Kerry mentioned, from the time I finished my testing to the time that a donor matches were found, and we had the surgery, it was probably 4 or 5 months. So it was a great experience for us. And just looking at my little notes here. So, the best part of all of that is that we got to preempt Kerry going on dialysis, which was definitely one of our goals. So for me, my surgery, it went amazingly well. I always say that my recovery, I was in some discomfort, but I was never in pain. And for me, that was my first major surgery I'd ever gone through. That was a real important differential to make, because it made the recovery so easy for me. And I remember 2 weeks to the day after my surgery, I came to see our surgeon, Dr. Beaulieu, who did both of our operations, and he said, "How are you doing?" And I said, "I would do it all again if I could," and I really meant it. And I wish I could. I can't, darn. But anyways, so that was 2 weeks later. 5 weeks after our surgeries, we took a little relaxing getaway to Vancouver Island, took it easy, and then probably about 9 or 10 weeks at the end of the summer, we took a holiday getaway, and we went swimming and short, gentle little hikes and kayaking. So we were back out in nature doing the things that we love to do. And now, over four years later, we do lots of that. So that picture in the bottom corner, I don't know if you can see the word on that stone bench, says transplanted. And when I came home from the hospital after my surgery, Kerry was still in the hospital for a few more days. The next day I had to go for a little walk, so my parents were in town to be with me, as was my sister. And the four of us headed out the door. It was a beautiful day. We walked for about 2 blocks near my house, and I had to stop. And I just happened to sit down on this bench, and I looked down, and there was the word transplanted etched into the stone. And so, it was freaky. So every year we go on our anniversary on June 20th, and we get our picture taken there. So I think that's last year's photo. This year's photo wasn't so good for some reason, but
It was backlit.
it was backlit, yeah. So that's our own little ceremony. So it's been it was a tremendous experience, and the best thing that happened of it is that Kerry is healthy. We have a lot of gratitude, for our friends and our family who supported us during that journey, and to the staff that I remember I worked with with the paired exchange program and all the hospital. We were at the hospital so much because there was a few complications not related to the transplant for Kerry the summer before. We were here so often that we would walk down the hall and we'd see an orderly, and it was one of those, oh yeah, we're back again. So we just have such gratitude for all of the staff at the hospital and our surgeon, Dr. Gourlay, but I'm especially grateful to everyone in the renal team here, because Kerry's been getting such amazing care for 22 plus years, and St. Paul's and the renal program here is a very special place in both of our hearts, and a very special place in my heart. And really, if I don't know anyone's story here, but if you're ever thinking of wanting to be a kidney donor and you're able to explore that option, I highly recommend doing that, whether you have someone in your life to donate to or not. You can be an altruistic donor, and if that's not an option, Kerry and I really believe in supporting financially the foundation, and would encourage you to do that, because I know that there's lots of work that they still want to do here. So thanks very much for listening to us. It was not really. That top story was the week after we were home from the hospital. And then the other photos, there's I think a couple more, are just photos of us in the past 4 years since the surgeries, being out and about and active and healthy, and just thought we'd show you that donors and recipients can be active and healthy. So we're just out doing all the things we love to do.
Thank you.
Thanks.
Thank you so much. It's a hard act to follow. I don't think I'll read Dr. Levin's bio. So our last speaker of the night is Adira, and there's very few ways to be like a megastar in medicine and in nephrology, like going by one name, Cher or Madonna, but Adira kind of does that. Every time you go anywhere in the world, they say, oh, do you work with Adira? And it's because you live in British Columbia or Canada. Dr. Levin is our UBC program, our lead. She is the executive director of the BC Renal Agency, so has a lot to do with policy and shaping how we care for renal patients. She actually is the president of the International Society of Nephrology. So when you think of the power we have here at St. Paul's to affect change for renal patients, we're pretty fortunate. I've asked her to talk today about a suite of research initiatives that have been recently funded. One of the, I don't know if she'll tell you the biggest, but one of the biggest funding ever for the care of patients with chronic kidney disease. And I think most of all, if any of you that have been cared for by Adira know she's a patient advocate at the heart of it all, and that kind of underlines the research agenda that she's going to talk about today.
So thank you, and I think that what you said at the beginning, that actually Kerry and Lauren are a very hard act to follow. And what I really wanted to tell this audience about is an amazing research initiative that Canadians should be really proud of, and it's called Solve CKD, which is Canadians Seeking Innovative Solutions to Chronic Kidney Disease. And it's a pan-Canadian network with patients at its center. The Canadian Institute of Health Research had a call out and said, you know, we need to do research that makes a difference for patients from the very beginning, where we engage patients, ask them what questions they want answered, and help to answer with them. And so with that, we took up the challenge, as we often do. And since, as Monica mentioned, kidney disease is often not well funded, we actually put together a patient-centered research program called Solve CKD, which got funded to the tune of $49 million, 12.5 of which came from the Canadian Institute of Health Research. And basically, there's over 120 researchers, 30 patients, 18 research projects. They're organized around 3 themes. The first one were things about how do we identify. People want to know, how come I didn't know I had kidney disease? How come no one told me? How come people in my family don't get tested? Those sorts of questions. And so how do we better identify who has kidney disease, when, where, and how, so we can prevent some of the progression? This is especially true of certain high-risk groups, and this is especially true of our Indigenous population. They're at incredibly high risk, not just because they have diabetes and high blood pressure, but because they actually have other kidney diseases. And we know that, and so one of our projects is to actually test every Indigenous person in this country, and most specifically in this province, in the next 5 years. Because if we could actually figure out who has it, then there's a huge amount of social impact that not taking people out of their communities by actually identifying their disease and subsequently delaying prevention or getting them preemptive transplants would actually change the face of the health of Indigenous communities. And there are some very interesting things that people with Indigenous people with diabetes get their diabetes and kidney disease much earlier than other people do with diabetes. And so this is affecting the youth, and that affects families. And so this is a huge component of this Solve CKD, in addition to the fact that we're trying to actually look at novel therapies. There are many very inexpensive drugs that are fantastically useful for kidney disease, but haven't been tested properly for people with polycystic kidney disease, as well as some other diseases. And so we're going to be able to test those in novel ways. And importantly, we across Canada are going to be able to participate in this and really change the way what we understand about kidney disease, for the whole international community. There are some things, we know that people on dialysis have a lot of heart disease. We haven't tested simple medicines that are good for heart disease in dialysis patients. So can we? Yes, we can. So we're going to try and organize that. And that's in various methods. There's various study designs that patients say they want to participate in, and other study designs that patients don't want to participate in. So we're trying to make sure that we do it the right way that is acceptable for patients, which is also novel. And the third theme is about defining optimal ways to deliver care. So what patients say to us is, how come I have to come all the way to clinic for a 15-minute visit? Can't you do this by telephone? Can't you do this by telehealth? Especially in this province, our rural and remote, not just Indigenous peoples, but there's a lot of things that we can do without seeing you. There's lots to be said for the human interaction, but there's a lot we can do remotely. And so how do we actually take the 21st century technology that we know we have and implement it so that we can actually have the patient experience be truly patient-focused? People want to have care, but all that care doesn't have to be physically centered in the hospital. And at St. Paul's, we have piloted and looked at creative ways to really, talk to people by telephone, put them on telehealth, see them, but not necessarily, make them travel. And that's a hardship. Lots of people don't have the money to travel. And so that's an important thing. And within and embedded in this Solve CKD is also the initiative to try and improve living donation. And I think BC will be a beacon in how we do that and how we test the various ways to look at better ways to have the donor experience. One of the donor families said to us, it's easier to change your religion than it is to give a kidney sometimes. And so that was the analogy that was used. And contrary to Lauren's experience, many people find it very cumbersome. So how can we change that? But the most important thing that we're also doing within this Solve initiative is something called knowledge translation. So often, when you do research, you get the result, but we actually then don't people don't necessarily follow the results. So even though we as doctors and patients have participated in the study, we don't always translate it into actual clinical practice. So one of the key things that Solve CKD will do is test best ways to translate the findings of a study into clinical care in real time, in our lifetime, in the time frame of the study. And that requires special tools and methods and a way to evaluate it. And what the patient said is, well, why don't you let us tell people what the results are, and we'll advocate for our doctors and the healthcare teams to take up the studies, because we actually were in the study and we know what the result is and we want it to be available to everybody. Sounds pretty simple, but believe it or not, that's relatively novel. And so these are the sorts of things that we'll be able to do, as well as developing tools that are culturally safe and sensitive, how you actually explain about dialysis and other things to people, irrespective of what their background is really important. And so all of these things will be tested in that way. I think that what is very inspiring is that a lot of the projects within Solve CKD have taken their root in a lot of things that we in British Columbia, with the team of nephrologists and nurses and dietitians and pharmacists that make up the kidney team, many of whom are based at Providence, actually helped to create. And so we were like the little mouse that roared, like ran ahead and did a little pilot and said, like, we think this can work. And so CanSolve will actually try and make that on a bigger international scale. So I appreciate that you've had a lot of people talk at you, and there are so many of you here that might have questions of everyone. So what I really wanted to say about CanSolve is really that Providence will play a major role in the execution of CanSolve CKD, that the learnings will be taken up as quickly as they're gotten, and that the people are always at the center of what we do, and the patients are the only reason that we have CanSolve CKD. And the fact that you are here to tell your stories, and others in the audience as well, actually helps us to move forward. And we have 5 years to show the world that we can change the face of kidney disease. So we're starting now. And St. Paul's Foundation has graciously helped to part of that 49 million fundraising was from St. Paul's Hospital Foundation, which was part of the way that the federal government was very inspired, that various foundations stepped up to give dollars. So this is about making the lives of people with kidney disease before dialysis, on dialysis, and with kidney transplants, the whole spectrum from cradle to grave, better. And so that's what I just wanted to let people know about. Thanks.
So I'd like to open up the forum for questions, and if everybody could come up, including Kerry and Lauren and Dr. Landsberg, Dr. Beaulieu, just in case there's questions, you're all up front, and they'll. So what I'll ask the audience for is, if you have a question, ask the person that it involves, whether it's patient, donor, or doctor, and if whoever it's directed to can repeat the question back, so then it's on the video as well. Okay.
All right.
Anybody like to start?
Can you please elaborate on this para exchange process?
Repeat the question.
So the question is just to say a little bit more about the kidney paired exchange program. Unfortunately, this is a place where a picture would definitely be worth many thousands of words to give you a verbal picture. But basically, the idea is that there's a donor who wants to donate to somebody, and so Lauren wanted to donate to Kerry, but she couldn't because they were incompatible. Across the country, there are many other pairs of people who are not compatible with each other, but are willing, the donor is willing to do it. So we now have a national system where all of these pairs are registered. Their information and their compatibilities and their incompatibilities all goes into a very sophisticated database, and through the computer can then come up with matches. So if this person donates to this person, and this person, their donor donates to this person, and then the donor of the next one donates to this person, everybody can get a transplant, but but not from their loved one who wanted to donate to them. But at the end of the day, everybody gets transplanted. We try and do them all around the same time because we don't want to leave a situation where somebody has donated, let's say, and then the recipient can't get it or something like that. So it's logistically challenging, and we've been able to pull some of that off. It requires an awful lot of resources, and St. Paul's has been absolutely phenomenal in supporting those resources to get these pairs done. Does that sort of explain it?
It does. Of course,
Good.
it does. There's more questions. Does this occur in one location, or are you looking at?
So it's national now. We started off just locally, but now it's national. So Lauren might have matched with a recipient in Toronto, and somebody from Halifax might have come here to donate to Kerry. So it's a national program.
Everybody gets together in one physical location?
No, so we try to do the transplants in the donors, in the recipient's hospital. So if Kerry's, we don't ask the recipients to go somewhere else, but we ask either the donors to travel, or sometimes we will ship the kidney to that location and do the transplant at that location. So there could be transplants going on in 5 different hospitals in 5 different cities all at the same time. Yeah.
David, if I could add to that.
Sure. Kerry's going to add something.
On the ground, what that really meant was access to that program. Once it was determined that Lauren was not compatible, then we went into the paired exchange program, which was basically just down the hall from in the same clinic. And it's through Canadian Blood Services, where they have the data bank, and they do the matching there, and it kind of spits out like, okay, who's the best match and where are they? So logistically, that's how that works.
Thank you. Thanks.
Yeah, so I would say the majority of kidney disease would need testing. So it's really looking at risk factors. So not many people would just develop end-stage kidney disease without some clue, but sometimes the clues can be subtle. Medications that can cause it, if there were ever stones or if they had infections. So sometimes they're subtle and they're gone, and the damage was done. Sometimes it was, as a young child, had infections and then forgot to follow up, hypertension, diabetes. So very rarely do we find someone who had no medical conditions, no real risk factors, and then just comes on our doorstep with significant CKD. It happens, but it's not common. So usually it's educating the population about the risk factors for CKD, and then from that to reach out and screen people. And just blood test and urine sample is all that's needed for a screen. That's it. Same test for a diabetic, just a bit more often. Yeah. Yeah.
So you can determine compatibility with blood because although, what we're looking at is what's happening, in the donor's kidney and the recipient's immune system, in the blood compartment, there are cells which are very similar to and have the same signature as the cells in the kidney, and so that will substitute for directly matching between the actual tissue of we call it tissue typing, and people get a little bit. You say, well, what's this tissue? Well, the tissue that we can use are the blood cells. These guys are all. Everybody here is an expert on polycystic kidney, so I won't hog the mic. I won't hog the microphone.
There's two kinds. One's a recessive and one's dominant, and most of the adults that you see have dominant disease, which means that 50%, you have a 50-50 chance at every child that you have of having polycystic kidney disease. So each child has a 50% chance. So there are some people that have a spontaneous mutation, or if you looked, so there's some people that have a spontaneous mutation, and that happens in about 15% of cases where you can't find a family history anywhere. But then once you have it, you are passing it on.
So that's a great question. So the question is, what are the risks to the donor? And I guess my career focus right now is about donor risk, and being able to look at a donor and say, this is your risk of kidney disease. You know, even if you get up and leave here and never donate, because everybody has some intrinsic risk, and then what would be the additional risk to somebody by having given a kidney. So it's clear that kidney donation on its own, with a healthy person with two healthy kidneys, doesn't cause kidney disease itself. So one kidney, if the person is healthy, there's no reason why that kidney would develop disease and wouldn't fail. Even, you know, people say, well, it's working harder, could that be bad for it? No, there's tons of experience to show that a normal healthy kidney can function on its own. However, if a donor then develops a problem which can cause a kidney problem, like diabetes or like high blood pressure, and there's only one kidney, and that problem is causing some deterioration of kidney function, stands to reason that somebody would end up with kidney failure more quickly with one kidney than with two, because just simply because they have less reserve. So we are able, I think, to do a pretty good job of telling people what their baseline risk is of kidney disease, and say, well, if you donate, I don't know how much it multiplies, but it multiplies a little bit. But say if your lifetime risk now is 0.2%, 2 in 1,000 chance of getting kidney disease because you're very healthy, you don't have diabetes, you don't have high blood pressure. If something happened to you, yeah, that would be bad, but the chances of something happening to you are pretty remote. So even with donation, even if the risk, your risk goes up a bit, it's going to be under 1%. When that baseline risk is higher, that's when we're reluctant to advise on kidney donation. So everybody gets a very thorough workup to try and gauge the health of their two kidneys and their risk of future kidney disease, and then if that future risk is high, or if there already is kidney disease, never mind. So clearly if the kidney function isn't good, then it's not the right thing to do. But if you have perfect kidney function, then we do our best to gauge the future risk. And then if somebody is at very high future risk, because let's say if both parents have diabetes and father is on dialysis because of kidney failure and one of his siblings also did, maybe it's in the cards. And so we don't want to put a donor in a situation where they're going to be at risk. The number one guiding principle in our living donor program is safety for the donor. However, if you don't take risks, then nothing happens either. So it's a matter of balancing those risks. And we have a very, I could go on and on and on about talking about balancing risks, because that's my current passion. Thanks for the question.
Is there an age limit to a donor?
Good question. So the question is there an age limit for a donor? We've been pushing the boundaries. As you age, it's more likely that you could have something going on with you. And even though you would have two good kidneys would be good enough to last you the rest of your life, they might have taken a little bit of a beating already. So they're fine for you, but the kidney wouldn't necessarily be fine for somebody else. And so, but there are super healthy people who are, even in their 80s, who potentially, we haven't gone that high, but we keep an open mind, and it's way more likely that we would say no, just because the kidney's been through a bit already. But so I like more to go by the physiology. How much, how good is that individual, rather than just by what the calendar says.
How high have you gone?
75, 76 maybe. 76, and we've recipients. We've done a number of people, who are over 80. 81 was our latest. I think is now our record.
As a donor?
Recipient, but donors in their mid 70s.
Wow.
But they're few. If you took 100 people who are 75 and they say I want to be a donor, most of them would be no. But But just by having an age limit and saying automatically no, that doesn't make sense.
So it's probably one of the most common questions we get about, does it affect both kidneys? And most kidney diseases will affect both kidneys, other than if you needed one out for a cancer or something, or had an obstruction of one side. Most will affect both kidneys. So most of the diseases that affect your body and then your kidneys will affect both. The symptoms are subtle, and the symptoms we tell people to watch out for are things like fatigue, appetite changes, a little bit of nausea, a little bit of itch, a little bit of cramps, and I'm sure others in the audience can tell me what they experienced. Often people don't even know they have them until after they've had a transplant or got better kidney function and said, oh, I didn't quite feel like I didn't sleep as well, I didn't feel as well, and I'll defer to others. We do monitor symptoms with like a scale now, and it's really surprising that even people with kidney numbers as low as 6, where we'd otherwise start dialysis, the symptoms are subtle, and I think we take quite good care of patients with all the allied health that are involved, that many of them don't have a high symptom burden, or their symptom burden is due to all their other chronic issues versus the actual kidney failure.
So the question is, what percentage of kidney transplants are for people with polycystic kidney disease and kidney failure in general? About 10% of people who are either need a transplant or end up on dialysis are from polycystic. So it's by far the most common genetic disease that affects the kidneys. But it's probably the 3rd leading cause or the 4th leading cause of chronic kidney disease.
Yeah.
So great question. So the question is, does it mean that a child of somebody who has chronic kidney disease shouldn't be a donor? It depends on the disease that the parent has. Most diseases of the kidney are not necessarily genetic, and so that doesn't mean that the trait for kidney disease is necessarily passed down to the child. And so we'll be very careful in terms of our assessment of what's the cause of your parent's kidney disease, and is there a genetic predisposition? And there's some things that aren't black and white, like diabetes. So if a parent has diabetes, then there's a higher risk of the child having it, but it's not all or none. And so all of those things would factor into that risk estimate that I was talking about, so that we can give potential donors an idea of what their future risk is. But if we feel that because of the family history and other factors that the future risk is high, then we would do it. But I would encourage people to look into it rather than just say, oh, it's my mother and she has kidney failure, so I shouldn't do it. That's not necessarily the case at all. So if somebody actually has diabetes, it's not a good idea. In my opinion, it's not a good idea. In Japan, where they have a very low deceased donor rate, they've actually had donors who I started a program where they actually accept donors who are diabetic. I'm, I guess, a little bit more conservative because of the fear that the donor could then develop diabetic kidney disease, and we're going to then hasten the progression of that kidney disease because they're starting off with less good kidney function. So I'm not there yet with frank diabetes. I think that's probably that's a reason why I would say somebody should not donate.
What percentage of your transplants are for excessive NSAID regestion?
So the question is, there's a cause of kidney failure which is related to heavy use over a long period of time of anti-inflammatory drugs. So in the term is NSAIDs, non-steroidal anti-inflammatory drugs. So that's basically your ibuprofen, Motrin, naproxen, etc. You got to take a lot of that, and you got to take a lot of that over a very long period of time, and it's rare. It's really rare. I would say, maybe not even every year, maybe every 3 years there might be somebody who has that diagnosis. So it's not common.
There you go.
Sure.
So the question is, when you have a lower GFR, what are the strategies there are to maintain it? So some things.
I'm just going to interject. Dr. Levin is probably the world, honestly, is the world's expert on this. If you said to somebody in the world, who should I talk to about delaying or hanging on to kidney disease, the Dr. Levin would be the. I'm not joking.
You might be in the right place, yeah.
I have to. Sorry.
So there's a number. So first of all, there are some diseases where you cannot modify the trajectory. And so that's important for us to be honest about. What you can modify in those diseases is all the other things that go along with losing kidney function, like the heart disease and blood vessel disease. And so we try really hard for that. The three cornerstones of treatment are actually control of blood pressure, control of blood sugar if you're diabetic, and maintaining good nutrition, and avoiding drugs that'll hurt you, or getting dehydrated when you're sick, and avoiding those things. And we know that if you do that in a concerted effort, and we also know that education of patients and regular follow-up has actually been shown to delay the progression of kidney disease in many chronic conditions, but also in kidney disease. So just by virtue of attending a clinic, a multidisciplinary clinic, 3 times a year, you have a better outcome than if you only attend once a year. For the same level of kidney function. And so there's a lot to be said about patient empowerment, understanding, so that you can avoid the drugs, so that you can avoid getting sick and be on the right drugs at the right time. And that's very much the philosophy that we put in the kidney care clinic, but also in our dialysis clinics and in our transplant clinics, is that this notion that being seen and having this holistic approach to care is one of the ways that you delay progression. And there are, as I said before, there are some new drugs and there are some old drugs that we know stop scarring. And so we're thinking that these might be, given at the right time in the right people, maybe another way to delay progression.
Could I add to that?
This is the other expert.
Yes, I think another helpful answer to that question would be, as Adira said, diet. And when you are in the with the program, you see the dietitian a lot, and through diet and through your diet, you learn which foods will help slow things down. Say like low protein diet, and they really help you learn what foods are best for you. And how to really mitigate the symptoms, or say not eating tomatoes so you don't get itchy as the phosphorus rises to the top of your skin, things like that. So that's very helpful in that program.
Well said.
Any other questions?
Few more transplants in a year?
We will.
So, great question. So the question is, could we handle more transplants? So last year at St. Paul's Hospital in 2015, we did 159 transplants. When I started here, actually the first year we did a lot because Vancouver General wasn't doing any, so we almost did 100 our first year, but then it was a long time after that. The hospital, St. Paul's is committed to the transplant program. If there's a donor, either a deceased donor in their kidneys, or there's more living donors, we'll accommodate it. It may require some stretching, but I have complete confidence that we've always risen to that challenge. If you said 159 5 years ago, I would have said, I don't know, but we did it, and we did it. Wayne is now our anyway. He'll say it's a bit of a it's hard, but we can do it.
Next year?
I don't think that So the question is, can we do 300 next year? I'd love to give it a try.
Any other questions? No? Okay, well, thank you all for attending. We do have gifts for you on your way out. And while I'm saying that, I do have gifts for Lauren and Carrie for speaking tonight. There you go.